capsule.
A very good evening, everyone. At the outset, I thank the scientific committee for giving me this opportunity. I will be presenting a study of topographic indices of 800 eyes of corneal ectasia presenting to a tertiary care center. There are no conflicts of interest and no financial interest. Corneal ectasia refers to a group of disorders with thinning and conical protrusion which causes visual distortions which cannot be corrected with spectacles. Keratoconus is the most common corneal ectasia, followed by PMD and keratoglobus, the conditions which pose significant challenges in management and visual rehabilitation. The current study aims to observe and analyze the topographic indices of corneal ectasia and also describe the clinical signs in a subset of these patients. All patients with clinical and or topographic signs of ectasia were included. Trauma, surgery, active allergy, scarring either due to hydrops or subepithelial scarring, or an inadequate quality of scan were excluded. It's a prospective observational analytical study of 798 eyes of corneal ectasia who presented between February 2023 to August 2024 in accordance with the inclusion and exclusion criteria and after obtaining informed consent and institutional ethical clearance. They were looked for the following clinical signs: a refraction of more than -2 diopter sphere and or a -2 diopter cylinder with best corrected visual acuity not improving to 20 by 20 in either of the eyes, a scissoring reflex and other slit lamp lines. All these signs were confirmed by 2 trained corneal surgeons and documented in a pre-validated proforma. They all underwent pentacam stream plug imaging and the clinical details and topographic indices were documented. Out of 798 eyes, 748, that is 93.7% were keratoconus, 5.8% was PMD and 0.5% was keratoglobus. The topographical data was analyzed by statistical softwares and the refraction and BCVA were described in 248 of 748 eyes. The minimum age at presentation in our center was 9 years with the maximum of 42 years with a median age of 19 years. 54% were females and 46% were males. The average duration of spectacle usage in these patients were 4.18 years and the most common systemic illnesses reported were hypothyroidism and anemia. 3 were lactating mothers, 2 out of whom had severe keratoconus. The mean log BCVA is 0.37 which corresponded to 20 by 40 on Snellen's and 4 patients had a BCVA of 20 by 20 in both eyes with other topographical signs. When we looked at the clinical signs, the most common sign was prominent corneal nerves followed by corneal thinning, Fleischer's ring and Vogt's striae. And the mean spherical error was -3.6 diopters with cylindrical error of -4.93 diopters. When we looked at the topographical indices, the mean Kmax was 58.83 diopters which indicated the severity at presentation with a minimum K of 42.5 and a maximum K of 98.5. The 3.07% had mild keratoconus, 23% had moderate keratoconus, but a majority of 74% of patients had advanced and severe keratoconus based on the keratometric values. The thinnest local was 447 microns and the back elevation was 50.5 diopters with a D value of 9.57. When we looked at the inter-eye asymmetry, the mean of difference in Kmax between right and left eye is 0.7 diopters plus minus 11.3 and 18 patients had a Kmax less than 47 diopters in either of the eyes while the other eye had a significant increase in Kmax. An interesting observation is the topographical asymmetry. 3 patients had a Kmax of less than 50 diopters in both the eyes, but out of these 3, 2 patients had Kmax of 49 which is similar in either of the eyes, but there was a significant difference in the posterior elevation and the thinnest local. And in one of the patients the keratometry value was less than 45, but a significant thinning of the cornea with a normal posterior elevation and a significant alteration of ART max. So this re-emphasizes the importance of other factors which influence the corneal thinning and also corneal ectasia like inflammatory markers. The thinnest local is negatively correlated with Kmax, back elevation is positively correlated with Kmax and negatively with the thinnest local, and the log BCVA is positively correlated with Kmax. The PMD contributed to 5.7% with the mean age of 31 years and a mean Kmax of 55 diopters and the thinnest local of 482 microns. The median age was 19 years in our study which correlated well with a study by Jagjit S. Saini et al. The mean thinnest local of 447 microns and a mean Kmax of 58 diopters indicates that majority of patients presented at a stage where a cross-linking is required. This can be attributed to the center being a referral center. The patients are referred for collagen cross-linking. The mean log BCVA is a 2-line reduction in Snellen acuity. The mean spherical error is -3, cylinder is -4.9. Though the cylindrical error of this magnitude raises an alarm for the disease, a sphere of -3 with no improvement in BCVA to 6 by 6 should also raise the suspicion. The limitations of the study, KC suspects were not included, and a wide range of Kmax with high standard deviation. Keratoconus being the most common ectasia and the affected population being young, there is a need to study the existing prevailing patterns. Further studies correlating the clinical signs, biomarkers, and biomechanics, probably AI, would shed more light on pathogenesis and thereby help in the management. These are my references. Thank you.
Thank you. Thank you.
Thank you.
Ready? Yeah.
Yeah, I have pressed it. Hello. Good evening, everyone.
Yeah.
Today I am going to present on corneal microstructure changes by in vivo confocal microscopy in different grades of VKC. So as we all know, VKC is a chronic bilateral seasonal allergic inflammatory disease of the eye which involves both tarsal and bulbar conjunctiva. VKC commonly occurs in school children between 4 to 7 years of age and more of preponderance in young males and in dry and hot climates, and it's a multifactorial disease which includes both the type 1 hypersensitivity reaction and also the cell-mediated immunity. Clinical features vary from papillae to cobblestone papillae, Horner-Tranter's dots with blinding complications like shield ulcers and LSCD. Bonini et al. Classified the VKC into mild, moderate, severe and very severe based on symptoms, signs like hyperemia, conjunctival secretion, papillary reaction, HT dots and corneal involvement. We use Bonini et al. Classification in our study to grade the VKC. So in vivo confocal microscopy, it provides higher resolution images. It is based on confocality and it provides the images at cellular level in different depths. So there are studies which have shown decreased nerve density in VKC patients in IVCM, but there are no studies which compare it with the clinical grading. So we investigated the subbasal nerve plexus changes in varying grades of VKC by IVCM by comparing it with controls. So it was 6-month study, prospective comparative study. All the diagnostic VKC patients were involved, which were above 5 years of age, and uncooperative patients and active shield ulcers were excluded. Demographic data, medical history and proper ophthalmic examination was conducted in all patients, and the grading was done according to Bonini classification. We used a Heidelberg retina tomograph 3-row stock module confocal microscope. Here central clear nerve images were selected and analyzed using ACC metric software. These are the few parameters that were analyzed by the software. First is nerve fiber density. This is number of fibers per millimeter square. Nerve branch density is the number of branch points on the main fibers per millimeter square. Fiber length is the total length of nerves. Fiber total branch density is the total number of branch points, and nerve fiber area and nerve fiber width was done. So this is an example of a representative image that we get in the software. So the red line, it associates with the main fibers, blue with the branches and the green with the branch points. So 24 cases of VKC were taken with 45 number of eyes and 18 controls with 36 eyes. The mean age in the VKC patients was 13.79 and the controls was 16.1, which were a bit of higher age. Males to female ratio is 5:1 in cases and 11:7 in controls. And according to the grading, mild were 14 eyes, moderate was 17, severe 11, and very severe was very small cohort, which was 3. So images were analyzed using the software, and the quantitative variables between VKC and the controls are compared by the t-test, and ANOVA was used to compare the different grades. So when we compare the VKC with the controls, all the nerve parameters except the width were significantly decreased. P-value was significant in all the nerve values, nerve fiber diameter, branch density, length, and also total branch density. We also compared mild with controls. When we compared with mild cases with the controls, then there was a decrease in branch density parameter. In moderate and controls also there was a decrease in few of the nerve parameters. In severe versus control, there was a very significant decrease in the nerve fiber diameter and nerve branch density. When we compared parameters between different grades of VKC, that is mild, moderate, severe, very severe was not compared because it was a very small cohort. So all the values had significant decrease in the parameters, and also there was a progressive decline in the various grades of VKC. This is just an example of the image where we can see high reflective inflammatory cells in the IVCM image and also the decreased nerve density in the right side of the image. There was a small sample size for very severe cases, and also there was a smaller group of controls compared to the cases. Concluding this, even in in patients with mild VKC, they all demonstrated lower branch density compared to the controls. So this also suggests that nerve alterations can also be seen early in the disease. This may also be linked to the ongoing cycle of nerve degeneration and regeneration during inflammation. So more studies have to be undertaken to see the progressive changes in IVCM even during the course of the disease as it goes, and also if they can see any reversibility of these changes on treatment. Thank you. Thank you.